Welcome to ATCM, the Emergency Medicine Channel.
Okay.
Presenting the case of a 24-year-old male who came to ER with complaints of fever, body ache and backache since last 5 days. Along with patient had a bifrontal headache during the initial 2 days of the fever. On initial 10-second assessment, the patient was conscious oriented and was obeying commands. The airway was patent. There was no pulling of secretions or gurgling sounds. He was able to complete and talk in full sentences. And breathing, the saturation was 98% in room air, respiratory rate of 22 per minute. The air entry was bilaterally equal and there was no presence of any added sounds. And the circulation, the heart rate was 100 per minute and BP of 120/70. All peripheral pulses were palpable and equal and capillary refill time of 2 seconds. And disability, the GCS was E4, V5, M6. Pupils were equal and reactive and the patient was able to move all four limbs. And exposure, the temperature was 101.5 degree Fahrenheit and there was no presence of any rashes. The patient had a pain score of 7 out of 10 and patient also had a temperature of 101.5 degree Fahrenheit. So
tell me something about pain ladder.
Pain ladder, there's presence of it's usually in the WHO pain scoring system is usually for cancer
Basically it is designed for cancer pain. Later it is extended to any chronic type of pain. Acute pain, it is not very useful, but whenever patient come to emergency room, pain is one of the important vital sign. If we are not able to control the pain, then everything will be like his heart rate will increase, ejection fraction will come down because of the tachycardia, anxiety will increase, adrenaline will release. So many problems can happen because of the pain. So pain control is very, very important in ER.
Yes. So this patient had a pain score of 7 out of 10. So we had given an injection paracetamol, 1 gram IV stat was given. Following which we...
Fast hug, you don't know, fast hug. What is fast hug?
Fast hug is mainly in ICU management.
That second is what? Second. F is something. A is what?
Analgesia.
Comes first. And ICU, now feeding is most important. So previously we used to tell delay the feeding, wait for some time. But now as soon as possible, we have to start feeding. Second thing is analgesics. Pain management is very, very important, both in ER and ICUs.
Yes. And after giving paracetamol, after 15 minutes we reassessed the pain and it was reduced to 3 out of 10. And we took adjuncts to the primary survey. We had taken a CBC.
What is the difference between paracetamol, IM and IV? We had given IV, that's why I'm asking.
Yes. So IVs more bio.
It's all same. Bioavailability is same. IV is more convenient for the doctor or nurse. That's all. Other one is painful. IM is painful. That is only difference between IV and IM. Otherwise, both are same. And it is much cheaper. IM is much cheaper. Only thing is, it is painful to the patient.
So we had taken a CBC CRP. We had taken a point of care showing an hemoglobin of 16, hematocrit of 45.5, platelet of 77,000, and a total count of 2,850. And with the differential count of neutrophil 62.4% and lymphocyte of 34%. And we had also taken a VBG, venous blood gas was taken, showing no acidosis or alkalosis. Hemoglobin of 16.1, potassium 3.7, sodium of 1.
What is the difference between ABG and VBG in pH?
pH, there is a mild variation of 0.1 to 0.03.
Very, very minimal. 0.1 is an important thing, but 0.03 it's a very minimal change. Okay. So, where all you want to know whether it is acidosis, alkalosis, and metabolic content of acidosis, alkalosis, you can do VBG. That is less painful. Because if you want to know the exact acid-base balance in respiratory conditions, then ABG will be better than VBG.
And we had done a creatinine of 1.1, bilirubin was 0.7, bicarb of 24 and lactate of 1.1. We had taken a sample history. The patient was a 24-year-old male. He was a known case of diabetes mellitus. And he came with complaints of high-grade fever with the diffuse body ache and backache since the last 5 days. And patient also had bilateral frontal headache since in the initial 2 days of fever, which had then resolved on arrival to ER. There was no history of any nausea, vomiting, or any breathing difficulty or any abdominal pain. And there was no history of any bleeding from the mouth or gums, gum bleed or any nose bleed. There was no history of any abdominal discomfort. There was no history of any travel to any dengue or malaria in endemic area. And there was no history of any reduced urine output or pedal edema. There was no history of rashes over the body. And there is no history of exposure to canal or water body source. And allergic history, there was
you want to rule out leptospira?
Yes, sir. And allergic history, there was
what is the difference between leptospira is spread from stagnant water or flowing water?
It can be spread from both.
What is the literature says? It is
Stagnant water.
Stagnant water is mainly all these conditions, whereas your hepatitis A, E, all these things, even flowing water can induce. Leptospira is always in the stagnant water.
And the allergic history was not allergic to any medication. The medication history, he was taking metformin, he was taking 500. And it was taking BD. And
what sort of drug is metformin?
Metformin is a biguanide.
What is the action?
It acts in the insulin sensitizer.
Insulin sensitizer. Once you tell that word, it is like everyone will understand.
Yes. And so the past history, he is a known case of diabetes mellitus since the last 5 years. And the last meal he had taken 2 hours back. And initially we had because platelet count was 77,000.
When you are taking last meal history, every patient you take, no? What is the need? Let them take. You put any time.
No, we just wanted to. In case airway is getting
airway is compromised, you want to know whether there is a chance of regurgitation and aspiration.
Yes. And initially, as part of treatment, we had initially told staff to avoid any intramuscular or intraarterial pricks because patient had a platelet count of 77,000. And also, we had initially started with injection. We had taken doxycycline was given initially as antibiotic, as 100 milligram. IV stat was given, and also we had given a fluid resuscitation with IV NS.
What is the BP?
BP was 120/70.
Why you want to give fluid resuscitation in this patient?
In this patient, the patient is having, we are suspecting
it. Is a medicine or is just given like that?
No, we didn't initially focus, just showing. IVC was collapsing. So
collapsing.
Yeah.
So what is the BP here?
120/70.
What are the signs of intravascular dehydration? One you told ultrasound shows collapse of the IVC. That is one. Second thing. If ultrasound is not there, how do you diagnose it?
JVP.
JVP. JVP. When there is dehydration, you cannot see it. What you can see, what all things you see?
Tongue. When you are looking at the tongue, dry.
Okay, dry tongue.
Yes,
okay.
Sunken
eyes. Okay, that all occurs in children, not in adult. What is more evident on when you are treating a patient for dehydration? Urine is a good marker. If you admit in ICU, then you will come to know hourly urine output. But ER, how do you know that? Suppose somebody is admitted here with 120/80, BP is normal, but still you are telling patient is dehydrated because intravascularly you have seen something.
Yes.
But if ultrasound is there, you can do all this. If it is not there,
vitals, maybe tachycardia can be present.
Most important thing is before the onset of hypertension itself, heart rate will increase. Tachycardia. What is passive leg raising test? Passive leg raising test. What is it?
We get an idea whether fluid resuscitation.
You tell me exactly what it is.
Raise the leg.
So
release the
venous return.
We are not seeing the vein now. BP will increase. Yes. Ideally, we need to have a central line, arterial line to monitor that. But even then, when you are lifting the leg, if the BP improves, that is a sign of dehydration. You can give more fluid. Capillary refill time.
Yes.
Okay, so you have to tell all these things: capillary refill time, pulse, passive leg raising, and ultrasound shows in IVC collapsibility. Then your findings are complete.
Yes. And also we have taken an ECG also, which is showing a normal sinus rhythm. And we had also done as labs, we had done routine complete blood investigations of like complete blood count. We had sent to labs, and also we had done a dengue. We are suspecting a dengue, so dengue NS1 was done, and also presence of tropical fevers, like presence of could be a leptospirosis. We had sent a leptospira IgM, and we are also sent the
How many days fever?
For the 5 days. Yes, and we are also sent for the malaria antigen, and peripheral blood smear was also done. And for this patient, the total labs CBC initially came with hemoglobin of 16.1, platelet count of 76,000, and a total count of 2,800. And with
Is he alcoholic?
No, no previous history of alcohol. With the PCV of 45.5.
Is it normal?
Yes. Normal.
Up to 50 is normal. More than 50 only we should consider it as a high value.
Yes. So, and we had also done the serum electrolytes showing a sodium of 132, potassium of 4.2, and the total bilirubin. We had also done LFT showing total bilirubin 0.74, that bilirubin 0.23, and SGOT was 95, SGOT PT was 86.8, and serum albumin was 3.9, LDH was 440, and we have also done a serum ferritin which showed 3000.
So what does it mean, ferritin more than 1500?
Yes.
Means what?
Ferritin is usually a sign of acute
inflammatory marker. Very high ferritin levels always indicate towards
the possibility of activation, like macrophage activation.
Okay. So macrophage activation is likely in this type of patient, but very high level of ferritin always indicates severity of the disease.
Yes. And then we had, because the patient is also having non-comorps and also showing signs
What
of
are other lab findings of macrophage activation
syndrome? There will be presence of elevated LDH and hypertriglyceridemia, and very low platelet count.
No platelets then. So triglycerides, platelets, ferritin. Anything else is there?
And, fiber not
lab. 3 is enough. 3 p.m. Okay. 5 minutes. Okay.
Yeah. So, and fibrinogen levels also will be reduced. And in USG, there will be presence of hepatosplenomegaly. So in this
extended dengue syndrome.
In extended dengue syndrome, there will be the presence of additional organ manifestations.
Normally, dengue will not have organ involvement. Here, organ involvement.
Mainly, it could be the involvement of a neurologic involvement.
So, what do you think what are the reasons for hypertension in dengue?
Dengue, there could be the presence of capillary leak. Okay. Capillary leak is one of the major reasons.
What is the evidence of capillary leak in your lab investigation?
Lab investigation, there will be the increase in hematocrit.
Hematocrit fluid loss will be there. Okay, yes. Correct. Then what is it?
And albumin.
What is albumin in this?
Inspiration was 3.9.
So it is not, patient has not developed that vascular leak. Now initially vasodilatation will be there. Initial vasodilatation, then vascular leak, hypoalbuminemia, hypotension. So here the patient will be in the phase of vasodilatation.
Yes. And in extended dengue, the patient could have presence of GI manifestations also, and also myocarditis and associated heart also.
ECG, how do you diagnose myocarditis?
There will be presence of global ST elevation.
There will be tachycardia and ST
depression will be there.
PR segment? PR segment will be depressed.
Depressed PR. And
whereas pericarditis?
Pericarditis will be ST.
What type of ST elevation?
concave
upwards.
Concavity
upwards.
And so for this patient, we are.
So how do you manage dengue normally? Dengue fever normally, how do you manage?
Dengue fever is basically based on how it is manifested, whether he's having showings of any warning signs. So presence of warning signs in dengue, usually if there is presence of severe abdominal pain, vomiting, and also if there is presence of hematocrit more than 50. In such
Hematocrit is a very important value in acute phase because high hematocrit always indicates volume loss. Okay, whether it is in trauma, diarrhea, dengue, everywhere it is always indicates volume loss.
And also if patient is having presence of any mucosal bleed, and also in USG if there is presence of liver enlargement, or clinically if liver enlargement more than 2 centimeter, that indicates a warning sign of dengue. So in such indications, we require an urgent ICU admission and also resuscitation with fluids.
Is there any vaccine available for dengue?
Yes, dengue varix.
Yes, sir.
This trial is going on.
Our hospital is doing the trial.
Yes.
So you should learn all these things. It's already under the trial. Our department of community medicine is doing the trial. Okay.
Yes.
How do you manage the platelet disorder here?
In this case, mainly we should look for signs of any bleeding manifestations is there or not. If patient is showing signs of bleeding manifestations and if platelet count is less than 20,000, might require platelet transfusion. Otherwise, if platelet count is less than 10,000, might require a prophylactic platelet transfusion. If patient is planned for any surgical procedure, platelet count should be kept more than 50,000.
Take this patient for a neurosurgical procedure, what should be the platelet count?
It should be more than 50,000.
Okay. If there is a major surgery, abdominal surgery, what should be the platelet count? 1 lakh.
1 lakh.
More than 1 lakh. Small procedure, 50,000, like a burr in the brain. But if you are opening the abdomen, it should be more than 1 lakh. What is single donor platelet and multi-donor platelet?
In a single donor platelet, it's from a single individual. Otherwise, the multi-donor is a like random pooled platelet. It's from multiple.
What is the main difference?
The difference is the concentration.
The concentration is correct. It is more concentrated. More antigenicity.
Yeah.
So multi-donor will have more antigenicity. Multiple donor platelets are there. Antigen will be large number. Like if you are taking 5 or 6 different type of antigens will be there. So antibodies will be formed against these 5 or 6 type of platelets. Because if you are giving single donor, only one platelet, one antigen, one antibody. Yes. So if you are giving continuously for a long time, like ITP and all, single donor platelet is always better. But whereas in dengue, even if you give 1 or 2 transfusion, multi-donor will be okay. Because the cost is very high. Okay. Single donor is around 10,000 rupees, 10 times costlier than multi-donor platelet. How many days platelet will live in your in your body?
One day.
Your platelet? 3 days.
1 to 2 days. 1 day.
Your platelet will live in your body for how many days? There is half-life of platelet. How many days? 7 days.
7 days.
to 10
7 days.
7 days. But a transfused platelet? 1 day. That is the difference. So we don't transfuse unnecessarily. Transfusion will be reserved for only medical emergencies. That you should remember. Unnecessarily, never give platelet transfusion because it is not going to remain in the body. Especially when the patient is exposed to multiple transfusion, it will not remain. ITP and all, how much can wait? ITP. You might have seen ITP.
Yes, sir.
10,000 is not the cutoff. Here 5,000, 3,000 our patient will remain stable. If you start aspirin, patients on aspirin, when you are doing some procedure, you are stopping aspirin. Previously it was for 7 days. Now, what is the recommendation?
3 days.
2 to 3 days. No need to stop it. You have to stop it. 2 days. 2 days is enough. Why? What is the reason they have reduced the time span? New platelets will develop that will not be affected by the stopped aspirin. Aspirin might have already produced some problem with the existing platelet, but every day you are producing new platelets. So That is enough. 2 days platelet load is enough to prevent any bleeding. So nowadays, like dental extraction, all small procedures, they are stopping only for 2 days. Previously, it was for 7 days. That is removed. Okay. Thank you.